So in the series of emergency medicine and emergency cases, today we will be discussing about asystole and pulseless electrical activity. So what is asystole or pulseless electrical activity? So when we examine the patient, there is no pulse and non-shockable rhythm on ECG. So ECG will show flat line or any other things not related to ventricular fibrillation or pulseless ventricular tachycardia. So what you have to do is actions. The first of all, you have to inform the emergency team, identify leader, call a code, call for the crash cart, assign a team member to read cognitive aid out loud. So if, as you know that this is not a shockable rhythm, so you have to initiate CPR immediately. So the rate should be 100 to 120 compressions per minute and minimize breaks. The depth of the chest compressions should be more than 5 cm and every time you allow chest recoil. Keep EtCO2 more than 10 mmHg and diastolic blood pressure more than 20 mmHg. If the EtCO2 is less than 10 mmHg or diastolic blood pressure is less than 20 mmHg, then the CPR is inadequate or inefficient or there is some missing things. So you have to check whether there is leak of air from the ambu bag or endotracheal tube or etc. Rotate the compressors with rhythm check every 2 minutes. Place the defibrillator pads. If becomes shockable, then shockable rhythm, as you know, are ventricular fibrillation and pulseless ventricular tachycardia. So if during CPR you get VF or VT, then you have to immediately defibrillate the patient with 200 joules biphasic or 360 joules monophasic. Check pulse only if the signs of ROSC is there. ROSC means return of spontaneous circulation, and EtCO2 spontaneous arterial waveform rhythm change. Prone CPR at lower edge of scapula, okay if the airway is secured. Place the defibrillator pads and check the rhythm every 2 minutes. So discussing about the airway, you have to give 100% oxygen, which is 10 to 15 liter per minute rate. If mask ventilation is there, then the ratio must be 30 compressions to 2 breaths. If airway is secured, then 10 breaths per minute should be given to the patient with a tidal volume of 6 to 7 ml per kg. You have to take immediate IV access to give epinephrine or any other drugs which is used in CPR. Turn off the volatile anesthetic and vasodilating drips if any. You have to give epinephrine 1 mg IV push every 3 to 5 minutes during the CPR. If there is hyperkalemia, then you have to give calcium chloride 1 gram IV stat, sodium bicarbonate 1 ampoule IV stat, or regular insulin 5 to 10 units IV with dextrose D50 1 ampoule IV. If acidosis is there, then inject sodium carbonate 1 ampoule IV stat. If hypocalcemia is there, give calcium chloride 1 gram IV stat. If hypoglycemia is there, give dextrose D50 1 ampoule IV stat, which is 25 gram of dextrose. Then ECMO or CPB. ECMO stands for extracorporeal membrane oxygenation. The ECMO machine gives your lungs and sometimes your heart to a chance to rest and recover. Meanwhile, the healthcare providers treat the conditions you have. And CPB stands for cardiopulmonary bypass. So these facilities are available only in the tertiary care. Post cardiac arrest, if return of spontaneous circulation is there, arrange ICU care and consider cooling. Explore the H's and T's, which are the reversible causes, and ask the senior to come.